Now I would like to invite Dr. Hegde, Dr. RAGHURAJ, for giving his talk on multidisciplinary management of COVID-19 associated mucormycosis, taking it to the next level.
Good morning. So I'll be speaking about the multidisciplinary management. All my previous speakers have made my job a little easier. So basically multidisciplinary management, it's possible in multispecialty hospitals, and it's all a teamwork. So in our hospital we had a mucor team. So it was a mucor team, and there was very good exchange of information from each of the departments. So this is very critical to take decisions at a very fast pace, because mucormycosis was very we had to think on our feet and go ahead and take decisions, and sometimes very decisions we had to take, very difficult decisions which we did not want to take, but we were forced to because of the circumstances at that time. So, starting from first principles, there is a global guideline for the diagnosis management. This is by the consortium, by the European consortium of infectious disease specialists. So, the main gist of it is that we start with the surgical management with ENT and ophthal most of the time, and sometimes plastic surgery and sometimes neurosurgery or maxillofacial surgery is involved. Along with that, medical management is also of critical importance, because they have to manage the medical part of the disease, that is the milieu where the fungus takes root, and which is the root cause of the mucormycosis infection that has taken root in the patient. But that doesn't end the story. In the end, we have to do the rehabilitation as well. That includes a very painful and long process, that is with the diet and nutrition, and multiple reconstructions involving multiple disciplines. And then finally, in some patients, we have to do some prosthetic rehabilitation as well, because they have to get back to society, and people without a maxilla, without teeth, without an eye, they find it very difficult to face other people and get back to society and to the normal regular society. So it is important that we rehabilitate them once they are cured of the disease, because that is not the our endpoint is not to cure of the disease, but also to get them back to society. So, starting with radiology, it's already Tarjani's gone through the most important. So, investigation of choice is always MRI with contrast. It's important to have the contrast, because then we'll know where the necrosis is, where the angio invasion is. And if the patient is in ICU, and sometimes these patients are non-cooperative because of their multiple diseases, and in some cases financial problems as well. So in these we may sometimes have to do a CTPNS and make do with it. And we can sometimes also, because if we want to screen somebody for mucormycosis, we can do a CT scan, quick CT scan, which will be fast enough to, especially in patients with ARDS who are already going for a pulmonary CT. It's easy to do a head CT as well along with the lung CT. So the main image that we have to see is the T1 weighted fat saturation with TSC post contrast. This is where we get the most information from in a mucormycosis patient. So it's also important to choose the right imaging. In this patient is very mild. This is a post kidney transplant patient. So very mild orbital cellulitis. He just presented with that. And when we did the CT scan was ordered outside. So when we did the CT scan, we saw that there's just a mild sinusitis, and didn't look like there was a lot of orbit involvement also. It looked like just a reactive cellulitis. But when we did the MRI, we saw that there is active orbital involvement, including there is enhancement of the medial rectus and the superior rectus, and the sinuses were involved, including there is a necrosis right at the where it's not enhancing, somewhere in the, yeah. So in the ethmoid sinus, there is a necrosis there, which indicate that it is mucormycosis, and we could go ahead and do an early intervention because we were able to do the MRI in time. So surgical management, early intervention, surgical intervention has, this is what we have learned over the past 1 year, that early surgical intervention will save eyes and also morbidity and life. So preferably we operate with the ENT surgeon, the rhinologist and the oculoplastic surgeon operate together and operate, and depending on what is required, we do the necessary interventions. And like Namrata also said, no PLI is not an indication for exenteration, so we don't always go for exenteration as the, so even if the patient is not seeing from that eye, just having the globe is important. And extraocular movements is more sensitive than actually the vision as such, because that indicates involvement of the extraocular muscles. So that will give us better, better idea of a prognosis. So the three main goals of the surgical part of the treatment is the disease clearance. We should clear the disease of, because if we don't clear the disease, then then the medicines will not act, because it's an angio-invasive disease. So the whatever drugs that we're giving, it will not reach the nidus of the infection. So then histopathology and microbial study is important, so that medical treatment can be instituted, and sometimes sensitivity and fungal culture also is important. What we do as an orbit surgeon, the three main interventions is transcutaneous retroorbital amphotericin B, which Dr. Akshay will be speaking next after me, and orbitotomy and debridement, the limited orbitotomy and debridement, which already Dr. Tarjini has spoken already, and then exenteration, which Dr. Namrata has already told. So the orbitotomy and debridement gives a midway between the tram, which is the lowest intervention, and as well as the exenteration, which is the extreme kind of intervention. So, and the exploratory orbitotomy can be done both for saving vision as well as saving the globe. So it doesn't necessarily mean that if the eye is not seeing, we should go ahead with the exenteration. So multiple papers have come out, and then we see why it is there was such a big surge of mucormycosis after COVID. They've seen that the SARS-CoV-2 virus infects directly the acinar cells of the pancreas, and that can cause cell death and increase proliferation in the neighboring non-infected B cells, and also can cause impaired insulin production, and B cell differentiation also can occur. This causes hyperglycemia, which is not, with the patient is not able to tolerate, and then the diabetic ketoacidosis sets in, which sets in the fertile grounds for the mucor to go. So in this setting, an endocrinologist as in the part of the team is a very important. Also, it is important to note that many of these patients also are diabetics from a long time, and they also have chronic kidney disease as well. So nephrologist also is important, because we have to not just manage the patient with the surgical disease and everything, because we also have to manage their kidneys, because amphotericin B is a nephrotoxic drug, and then on top of that, their kidneys are not functioning well, and then there will be electrolyte imbalance, as well as their diabetes is very high. So I mean, the hyperglycemia is uncontrolled hyperglycemia is there. So we all have to work in tandem, because just the surgery will not get rid of the patient. The patient will not get rid of this disease just with surgery. So we start them off on a very high dose IV monotherapy with amphotericin B. Then we move on to a dual therapy after we have some degree of control. And then for many months after this intensive therapy, we wean them off the therapy with the oral posaconazole for sometimes up to 6 to 8 months. There are some other alternative antifungals which we personally I just came to know all these only once this epidemic had started. That there were other alternatives to mucormycosis. Isavuconazole was very helpful in patients who were post-kidney transplant as well as chronic CKD patients. And posaconazole is not a good standalone drug, it proved useful when we had acute shortage of amphotericin B. So the pathology and microbiology teams were the back end. They were the back end, and they were working very hard to get us the diagnosis as soon as possible. Initially, when we first had the first cases, it was taking up to a week to get a histopathological diagnosis. But they were communicating with us and told us to get nasal scraping so that they could get the diagnosis in, because if we do a swab or any other, we will not get the hyphae because the hyphae gets broken. So nasal scrapings was the way to get the diagnosis very fast. So we were getting it within 24 hours. Along with that, RT-PCR and histopathology, all of them were speeded up, and we were getting diagnosis. We were getting a histopathological diagnosis within 2 days, sometimes within a month or so, because they were doing so much of it that they were getting very, very fast with it. And fungal culture also was important. Fungal culture and sensitivity was also important, because then we would know which antifungals would work, and when we could optimize treatment and to patients who were sensitive to certain species of the rhizopus of the mucor fungus. So then also they were also giving us feedback regarding the bacterial infections and superior infections that we were getting, which I will give a few case examples. So the first case that I want to show is a 74-year-old woman who came with COVID-associated mucormycosis. It was diagnosis fairly easy then, but her vision was quite good, about 20/30, and only a mild restriction of in the lateral gaze, and there was no RAPD, and there's no pain on movement either. She had a 7th cranial palsy, and there was a little gingival and palatal discoloration. So then, so initially we went in with the intervention. This is the imaging findings where we could see that the left maxillary sinus as well as the orbit is involved. We went in with the to do a FES, and the plastic department did the palate debridement, and I gave the transcutaneous amphotericin B, so that because it was very minimal orbital involvement at that point of time. So post-surgery, because there was a time of acute shortage of amphotericin B, the patient was started on oral posaconazole. And like I mentioned earlier, oral posaconazole doesn't work as well as in a patient with active mucormycosis. So as a monotherapy. So after 3 days, actually it worsened, and there was increase in the orbital involvement as well. And we could see that even though we've cleared the sinuses of the disease, it has spread from the cheek area and the pterygopalatine area into the orbit, and it is increasing. All the muscles are increasing in size compared to the earlier, and then there was this the fungal granulomas forming in the cheek area as well. So then we had no option but to, at that point of time, consider exenteration and along with the radical surgery, because we were short of amphotericin. So it didn't make sense to do a maxillectomy and not do a so then we went ahead and did the maxillectomy as well as an exenteration. This is another patient who was 72-year-old who was okay. So I think we have another 5 minutes more, so I'll just run through the slides in another minute. And this is another patient where we had to operate, and initially we did limited treatment, and then we had to go through to the since it was increasing, we had to go to the second surgery, which was a little radical, but we managed to save the orbit because we just did an orbital debridement, and post debridement we did a maxillectomy also, but and then we could rehabilitate him with the processes, and he's waiting for a waiting for a free flap to be done and reconstruction of the left orbit. He has 20/20 vision. So this is another patient who spent about 45 days in the ICU. He came with COVID-associated mucormycosis. Then he had active COVID at that time, and along with that, he had a pulmonary bacterial infection as well, and the pulmonary reactivation of the TB. So he had like triple lung disease as well as COVID-associated mucormycosis. So but he went on to make a miraculous recovery because we intervened at the right time, and he's still on ATT, and he has 20/20 vision, and all his extraocular movements also are intact. So there is other mucormycosis sequelae that can happen, and this is lateral rectus palsy, which was treated with surgery, TRAMP, and systemic thing, and it was her lateral rectus palsy had recovered. And this is another suppurative osteomyelitis, which is secondary to the mucormycosis. And when we waited for the orbitotomy, we got pus coming in. And this is another case where again we had to do a lot of debridement, and we could save his vision as well as the orbit. Okay, and this some sphenoid abscess, and I think I'll stop at this point because I think it's running out of